Okay, let's unpack this. We've all heard of serotonin, right?
Yeah.
It's the happiness chemical, the shorthand we use for good mood and mental health.
That's the popular image for sure, the one that gets all the press.
But if that's the limit of your knowledge about this molecule, 5-hydroxytryptamine or 5-HT, you're missing about 90% of the picture.
At least, maybe more.
So today, we are undertaking a serious deep dive into the complex, often contradictory roles of 5-HT, far beyond the brain. We're focusing critically on how targeting its sprawling receptor system became the key to unlocking modern treatments for debilitating pain, especially migraine.
And this is a perfect mission for a deep dive because that common perception is so wildly skewed. The sources we've collected really demonstrate that 5-HT is this foundational ancient chemical messenger.
An autocoid, right?
Yeah, exactly, an autocoid. It mediates everything from your immune response to your digestion, and only secondarily really does it act as a central neurotransmitter. We are going to map this system precisely, showing you how understanding its, 14 different receptor subtypes allows pharmacology to perform molecular surgery.
And we start with the absolute giveaway that this molecule is not primarily a brain chemical, which is the origin of its name.
Right.
It didn't have one name initially. It had two, based on two completely separate functions observed in two completely separate parts of the body.
Indeed. The Dole discovery is a great story. It really tells you everything. In the blood research labs, scientists isolated a substance that was a powerful constrictor of blood vessels, meaning it narrowed them.
Okay.
And since they found it in the serum after blood clotted, they just, logically named it serotonin.
The vessel-toning substance from the serum. Simple, descriptive. Makes perfect sense.
Right. But then simultaneously, in completely different labs, the gastrointestinal researchers were studying the lining of the gut. And they isolated a substance that powerfully caused smooth muscles to contract, meaning it dictated intestinal motility. Because they found it in these specialized cells of the gut mucosa, the enterochromaffin cells, they named it enteramine.
Enteramine. So you have serotonin in the blood, enteramine in the gut.
And nobody connected them. It wasn't until the early 1950s that researchers finally figured out that serotonin and enteramine were identical. They were both 5-hydroxytryptamine.
Which leads directly to the distribution shock. In fact, I think every listener needs to just engrave on their brain.
Yeah.
If 5-HT is so famous for being a brain chemical, where is the vast majority of it actually located?
About 90%. A full 90% of the body's entire store of 5-HT is localized in those gut cells, the enterochromaffin cells of the stomach and intestines.
Right.
This makes the gut the primary manufacturing site, the primary storage site, and the primary release site for serotonin in the entire body.
So the remaining 10% is, split between the brain and the blood?
Mostly, yes. The rest is distributed mainly in platelets, where it's stored for use in clotting. And then that tiny fraction, the part everyone knows about, acts as the neurotransmitter in the brain.
90%. That completely reframes our understanding of its priorities. Its main job is clearly peripheral, controlling the environment within the body cavity, not necessarily regulating our mood.
That's a great way to put it. The mood regulation, while critical, is a specialized function. Its day job, its main job, is in the gut.
Precisely. And adding to this ubiquity, the sources point out that 5-HT is incredibly widespread in nature. It's a very, very old signaling molecule.
Oh, ancient. We're talking about an evolutionary veteran here.
So it's not just in humans.
Not at all. You find 5-HT in the venom of wasps and scorpions, where it actually contributes to the local pain and inflammation response you feel from a sting.
That's fascinating.
And interestingly, it's also abundant in plants. Things like bananas, pears, pineapples, tomatoes, and even in stinging nettles.
The thing that stings you also contains the thing that makes the sting hurt more.
Exactly. This sheer distribution reinforces its status as a fundamental communication chemical used across countless species for defense, regulation, and signaling. It's been around for a very long time.
So our goal today is to fully map this evolutionary journey. We'll go from its humble precursor, tryptophan, all the way to its incredibly complex receptor system.
And in doing so, we'll reveal how targeting just one or two of those 14 receptors was the pivotal breakthrough that finally gave us reliable, modern treatments for pain and migraine.
Right, moving us light years past the historical, frankly toxic approaches.
Exactly.
Okay, so to understand the pharmacology, we have to start with the foundational biochemistry. This is where we see 5-HT's close relationship with the other major monoamine neurotransmitters. the catecholamines.
CAs, right. Things like noradrenaline and dopamine, they're all part of the same family in a way.
Well, let's talk about building 5-HT. It all starts with the precursor we hear about often, especially around Thanksgiving, tryptophan.
Yes. Tryptophan is an essential amino acid, meaning we have to get it from our diet. The body can't make it. And the synthesis pathway from tryptophan to serotonin is remarkably short. It's just 2 enzymatic steps.
Just 2 steps. That highlights its efficiency, I suppose.
It does. It's a very direct conversion.
Walk us through those 2 steps.
Okay, so first, tryptophan is hydroxylated. That just means a hydroxyl group is added to it, and that transforms it into 5-hydroxytryptophan, or 5-HTP.
5-HTP. People might recognize that from supplement bottles.
They might. That first step is the rate-limiting step, the bottleneck in the whole process. Second, that 5-HTP is then converted into 5-HT by a process called decarboxylation.
And this is where the chemical parallelism you mentioned earlier gets really, really interesting, right?
It is the crucial connection point. The enzyme that performs the second step, the decarboxylation of 5-HTP, is a non-specific decarboxylase. It's the exact same enzyme that acts on DP to turn it into dopamine.
The very same one.
The very same one. And of course, dopamine then goes on to become noradrenaline and adrenaline.
So evolution used the same tool, the same enzymatic machinery, to finalize the creation of 2 major, chemically distinct families of signaling molecules. You've got the tryptamines, like 5-HT, and the catecholamines, like DA and NA.
And the consequence of that shared enzyme is significant.
What is it?
It means that pharmacological interventions targeting that enzyme, though they're rare now, would affect both systems simultaneously. But more profoundly, it shows that the body manages these systems under a shared logistical framework. Their pathways are chemically intertwined from the start.
Which probably influences how our body prioritizes resources.
It absolutely does, as we'll see later when we talk about conditions like carcinoid syndrome.
Okay, so now 5-HT has done its job. It can't just linger in the synapse or the body. How is it efficiently cleared out?
Its removal, or degradation, is handled primarily by a famous enzyme, monoamine oxidase.
MAO.
MAO, yes. Specifically, the isoenzyme MAOA preferentially handles the metabolism of 5-HT. When 5-HT is broken down, it produces the main metabolite, which is 5-hydroxyindole acetic acid, or 5-HIAA.
We hear 5-HIAA mentioned a lot in neuroscience research. So that's because measuring 5-HIAA is essentially a way of measuring the turnover rate of 5-HT in the body.
Exactly. If your MAO is working hard, you'll have high levels of 5-HIAA. It's a direct marker of activity.
And again, this use of MAOA reinforces that parallelism with the catecholamines, because MAO is common to both of their breakdown systems.
It is. This is why the early antidepressants, the MAO inhibitors, affected mood so broadly. They blocked the degradation of both 5-HT and NA simultaneously, which was effective but also messy.
Caused a lot of side effects.
Yeah.
Okay, let's turn to movement and storage. We established that 5-HT doesn't circulate freely in the plasma because platelets vacuum it up. How is that accomplished?
This requires a highly efficient active transport system. Just like noradrenaline, 5-HT is transported by a specific pump. It's called the serotonin transporter, or SERT.
SERT.
And this is a sodium-dependent carrier located on the membranes of serotonergic nerve endings in the brain, and critically for our story, on platelets.
So the SERT on nerve endings takes 5-HT out of the synapse to terminate the signal, basically recycling it.
Correct.
But the SERT on platelets is taking 5-HT into the platelet for storage. So it's the same piece of molecular machinery performing 2 different logistical tasks.
That's the perfect distinction. And because platelets acquire 5-HT so efficiently via SERT during their passage through the huge capillary beds of the intestines, they act as the body's mobile storage units.
Which is why 5-HT levels are stable in the plasma but high inside the platelets. They're just waiting, ready to be deployed instantly for hemostasis, for clotting.
Exactly. They're locked and loaded.
This transportation system's SERT is foundational to modern psychopharmacology. It's maybe the most important drug target we'll discuss today.
Without a doubt. Inhibiting the SERT pump is the primary mechanism of action for the most widely prescribed class of psychiatric medications in the world. The selective serotonin reuptake inhibitors,
The SSRIs.
the SSRIs, and the older, less specific tricyclic antidepressants, the TCAs, also inhibit SERT, though they hit noradrenaline transporters as well.
So if SERT is the vacuum cleaner that sucks 5-HT out of the signaling space, the SSRIs are essentially jamming the vacuum.
That is an excellent analogy. By inhibiting SERT, the drug increases the concentration and the duration of 5-HT in the synaptic cleft. You're prolonging its effect on the postsynaptic receptors, which then gradually leads to the therapeutic effects we see in mood, anxiety, and obsessive-compulsive disorders.
So once 5-HT is back inside that nerve ending or platelet, it still needs to be stored safely until the next release signal. It can't just be floating around inside the cell.
No, it can't. It's sequestered into small protective packages called vesicles. And this uptake into the storage vesicles is managed by another transporter, the vesicular monoamine transporter, or VMAT2.
VMAT2. And this is where we revisit another classic pharmacological lesson, the action of reserpine.
Ah, reserpine, a very important historical drug. Reserpine is famous because it specifically targets and inhibits VMAT2.
So it blocks the storage mechanism.
It blocks the storage mechanism. So if you block VMAT2, the 5-HT that has been transported back into the nerve ending has nowhere to go. It's left vulnerable in the cytoplasm where MAO, our degradation enzyme, quickly finds it and chews it up.
So reserpine doesn't directly degrade 5-HT, but by blocking VMAT2, its storage locker, it leads to massive depletion of 5-HT.
And all the catecholamines.
Right, because the storage mechanism is common to all of them.
Exactly. And this historical drug action of reserpine-inducing depression and lethargy by depleting these monoamines was actually key to developing the monoamine hypothesis of depression, which is what paved the way for SSRIs and other modern therapies. We see that storage, transport, and breakdown are fundamentally shared mechanisms.
Okay, we've built, transported, and stored 5-HT. Now we release it, and it hits the postsynaptic membrane. And this is where things go from complex to, well, astronomical, the receptor universe. Let's start with the simplicity of the early classification.
Right. When scientists first started mapping this, the world was very simple. They saw two main actions. Back in 1957, Gaddam and Piccarelli categorized them into two groups.
The D-type and the M-type.
The D-type was the dibenzyline blockable musculotropic type, which just means it mediated smooth muscle contraction.
And the M-type.
The M-type was the morphine blockable neurotropic type, meaning it excited nerve tissue. So it was a purely functional classification based on what the drug did and what blocked it.
That seems beautifully elegant, but I'm guessing it was completely insufficient for what we now know.
It is entirely insufficient. The modern system, which is based on molecular characterization and cloning, is vast.
Yeah.
We now recognize 4 major families, labeled 5-HT1 through 5-HT47.
And those 4 families.
Collectively comprise 14 recognized receptor subtypes. This sprawling array allows 5-HT to act like a molecular chameleon, mediating contradictory effects simultaneously across different tissue beds.
14 distinct locks, all opened by the same key.
That's incredible. We need a way to organize this. Let's start with the most fundamental division, the G protein versus the ion channel divide.
This division separates the rapid-acting from the slow-acting modulating effects. It's the most important split.
Okay, so which one is the rapid-fire outlier?
That is the 5-HT3 receptor. It's the only one in the entire family that is a ligand-gated cation channel.
A channel, not a receptor in the classic sense.
Right. Think of it as a rapidly opening floodgate. When 5-HT binds, it instantly opens a pore that allows positive ions, specifically sodium and potassium, to rush into the cell.
And that influx of positive charge causes rapid depolarization, an instant activation of the nerve cell. Because this corresponds to the old M-type, the neurotropic one.
Yes, exactly. And this rapid action is essential for mediating quick reflex loops, which is why 5-HT3 is central to the pain reflex, the itch reflex, and especially the vomiting reflex.
And all the remaining 13 subtypes, 5-HT1, 5-HT2, and 5-HT4 through 7, are G protein-coupled receptors, GPCRs.
That's right. Let's pause and give our listener a clear framework for what these G proteins actually do, because this can get confusing.
It can. So GPCRs are like molecular switches that modulate cellular machinery over seconds to minutes, not milliseconds. We divide them based on the G protein they couple to, Gs, GGO, or GQ.
Let's use an analogy, maybe something with an accelerator and brake.
Perfect.
Yeah.
Imagine the cell runs on an internal resource. Let's call it CMP, or cyclic AMP.
Okay.
The G's coupled receptors, which are 5-HT4, 6, and 7, are the accelerators. They stimulate an enzyme called adenylate cyclase, which increases KMP, and that drives the cell toward activation or secretion.
So G's for stimulatory.
Exactly. The GGO coupled receptors, which is the whole 5-HT1 family, are the brakes. The I stands for inhibitory. They inhibit adenylate cyclase, which decreases KMP, driving the cell toward inhibition.
And the last one, GEQ.
Finally, the GQ-coupled receptors, the 5-HT2 family, are the calcium mobilizers. They don't mess with ChemMP directly. They activate a different enzyme, phospholipase C, which generates these messengers IP3 and DAGI. This releases internal calcium stores, and that typically leads to contraction or excitation.
Accelerator, brake, and calcium release. That GSGT categorization is the key to understanding all 14 subtypes. So let's zero in on the family that acts as the brakes, the inhibitory 5-HT1 family, because this is the one that cures migraines.
Yes. The 5-HT1 family couples to GIGO proteins, so their primary mechanism is inhibitory. They decrease ChemMP. They are critical because they often act as autoreceptors in the central nervous system.
Meaning they regulate 5-HT's own release, like a feedback loop.
Exactly, a thermostat. They can also inhibit calcium channels or activate potassium channels, which leads to hyperpolarization and reduced neuronal excitability. They tell the neuron to quiet down.
Within this family, we have two major players. First, the 5-HT1A.
5-HT1A is highly concentrated in the Raphin nuclei, which is the originating hub for all the serotonergic neurons in the brain, and also in areas like the hippocampus. Activating this receptor literally inhibits the firing of those Raphin neurons. It slows the entire system down at its source.
And the drug connection here is an interesting one.
It is. The anti-anxiety agent buspirone is a classic example. It functions as a partial agonist at these 5-HT1A receptors. By partially activating these inhibitory autoreceptors, it helps to modulate and calm down overactive serotonergic circuits that are involved in anxiety.
But without the sedative or addictive properties of traditional anxiolytics like benzodiazepines.
Precisely. It's a much more subtle modulation.
Okay, now for the therapeutic jackpot. 5-HT1D and 5-HT1B. Why are these two specific subtypes the targets for migraine treatment?
It's all about location, location, location. They are strategically located exactly where migraine pathogenesis occurs in the cranial vasculature.
And their activation achieves what?
It achieves three distinct therapeutic goals simultaneously. First, they cause powerful constriction of dilated cranial blood vessels, especially those involved in the pain pathway. This is the most direct effect.
Okay, so it reverses the dilation that causes the throbbing pain?
Yes. Second, they act as presynaptic autoreceptors on pain fibers, inhibiting the release of 5-HT itself and also noradrenaline. And third, and this is arguably the most important part in stopping the pain cycle, they inhibit the release of potent inflammatory neuropeptides.
Things like CGRP and substance P.
Exactly. They block them from being released from the sensory nerve endings in the dura mater, the lining of the brain.
So by activating 5-HT1D and 1B receptors, you are simultaneously constricting the source of the pain, the dilated vessels, and hitting the chemical switch that initiates the painful inflammation, which is the neuropeptide release.
That's it. It's a two-pronged attack. And this is why the anti-migraine drug sumatriptan and all of its successors are selective 5-HT1D1B agonists. It's highly targeted molecular intervention.
Incredible. Okay, let's move to the other side of the scale, the excitatory 5-HT2 family. These are GQ coupled. They mobilize calcium. This is the old D type, responsible for muscle contraction.
The 5-HT2 family is highly versatile. They mediate contraction, secretion, and neural excitation. The 5-HT2A receptor is the most widely expressed post-junctional receptor, meaning it's found everywhere 5-HT causes a direct action.
And that includes what?
Strong vasoconstriction via smooth muscle, contraction of the gut, the uterus, the bronchi, and most relevantly to blood health, platelet aggregation.
If 5-HT2A mediates so many negative constricting actions, particularly platelet aggregation, then antagonizing it, blocking it, must have been a goal for drug developers.
It was, absolutely. The classic 5-HT2 antagonist is a drug called ketanserin. It was explored as an antihypertensive agent and for vascular disorders like Raynaud's because it blocks the vasoconstrictive and aggregating actions of 5-HT.
But I'm guessing it wasn't a clean block.
It wasn't. Its action was often complicated by cross-reactivity with alpha-adrenergic receptors, which limited its utility.
What about its sibling receptor, 5-HT2C?
5-HT2C has a surprising, almost contradictory function in the vascular system. While 5-HT2A on the smooth muscle causes it to contract.
Right.
5-HT2C, when it's located on the endothelium, the inner lining of the blood vessel, actually elicits vasodilatation.
It does the opposite. How?
It causes the release of endothelium-derived relaxing factor, or EDRF, which we now know is primarily nitric oxide. This just highlights the complexity. 5-HT can cause contraction and dilation in the same blood vessel at the same time, depending on which receptor subtype is expressed where.
That is critical. Two different receptor subtypes for the same molecule, mediating opposite effects on the same piece of tissue.
And we must also mention the rapid-fire ion channel. The 5-HT3 receptor. We already noted it causes rapid depolarization.
So what specific functional systems rely on that kind of speed?
The 5-HT3 receptor mediates rapid indirect and reflex effects. Most dramatically, it controls the emetic reflex.
Nausea and vomiting.
Nausea and vomiting. When noxious stimuli hit the gut, the enterochromaffin cells release massive amounts of 5-HT. This stimulates 5-HT3 receptors on vagal afferent nerves and in the brainstem, specifically the area postrema and the nucleus tractus solitarius.
The vomiting center of the brain.
That's right. And this makes 5-HT3 antagonism a lifesaver in chemotherapy.
I was just going to say that.
Exactly. The drug ondansetron is a highly selective 5-HT3 antagonist. By blocking this rapid-fire ion channel in those critical vomiting centers, it effectively shuts down chemotherapy-induced nausea and vomiting. It's a beautifully selective intervention against a single receptor subtype.
Finally, let's quickly look at these stimulatory G-coupled receptors, the 5-HT4 family, which are known as the gut regulators.
5-HT4 is GS-coupled, so it increases CAMP. It's richly expressed in the gut mucosa, the nerve plexuses there, and the smooth muscle. Its effect is to augment intestinal secretion and peristalsis. It basically drives the gut forward.
Which explains the pharmacological use here.
Right. Drugs like cisapride and renzapride are selective 5-HT4 agonists. They're known as prokinetics. They're used to increase gastrointestinal motility, addressing issues like reflux or chronic constipation. The existence of these specific agonists just further emphasizes how precisely we can now target the 5-HT system.
We have mapped the complex receptor universe. Now let's look at the systemic effects, particularly the surprising ones, starting with the cardiovascular system. We know 5-HT can constrict and dilate depending on the receptor. What is the net impact on the heart and vessels?
Well, the duality means the net result is chaotic and heavily tissue-dependent. While it acts directly on smooth muscle to constrict via 5-HT2A, it also promotes dilation via nitric oxide release, via 5-HT2C. And it also affects autonomic ganglia and promotes the release of noradrenaline and adrenaline. It's a mess.
So if you inject 5-HT intravenously into an intact animal, you get a textbook demonstration of this complexity, the triphasic blood pressure response.
This is a classic pharmacological observation that perfectly illustrates the multiple conflicting actions of 5-HT. The sequence is very specific.
What's the first phase?
First, there's an early sharp fall. Within seconds, the blood pressure plummets, and it's accompanied by bradycardia, a slow heart rate. This is due to the activation of the coronary chemoreflex.
Also known as the Basal-Gerish reflex.
The Basal-Gerish reflex, yeah.
So a big drop first. Then what?
Phase 2 is a brief rise. Immediately following that crash, there's a spike in blood pressure. This is caused by the direct vasoconstriction on large arteries and an increased cardiac output.
And the third phase?
The third phase is a prolonged fall. The pressure then settles into a long, low trough caused by a combination of arteriolar dilatation and also increased capillary permeability, which leads to fluid leaking out, causing edema.
Let's elaborate on that first part, the Basal-Gerish reflex. What is actually happening there?
This reflex is protective, but it's exaggerated by 5-HT. There are vagal efferent nerve endings in the coronary blood vessels that are incredibly sensitive to rapid changes in tension or flow. When 5-HT hits them, they basically scream to the brainstem that something is severely wrong, triggering a massive parasympathetic response. The body attempts to shut down.
And that results in the dramatic drop in heart rate and blood pressure.
It does, and this reflex is mediated by the 5-HT3 receptor.
That's a fascinating dramatic response. Yet, despite 5-HT having this dramatic, measurable impact on blood pressure in a lab setting, we concluded earlier that it's not involved in the physiological, day-to-day regulation of blood pressure.
And that is the key distinction. In physiological setting, 5-HT is rapidly metabolized by MAOA and efficiently vacuumed up into platelets by SIRT. It never achieves the necessary free circulating concentration to act as a systemic BP regulator. Its actions are localized, serving hemostasis and local vascular control, not systemic homeostasis.
Moving to the gut, the 90% reservoir, we know 5-HT is a stimulator.
It is the most potent stimulator of the gastrointestinal tract. By acting on 5-HT2 and 5-HT4 receptors directly and through the enteric nervous plexuses, it significantly increases peristalsis. Excessive 5-HT, like that released during food poisoning or in certain disease states, instantly translates to diarrhea.
What about its effect on gastric secretions?
Interestingly, it has a localized ulcer protective profile. While it's promoting motility, it paradoxically inhibits the secretion of gastric acid and pepsin, while simultaneously promoting the production of protective mucus.
So it seems to tell the gut, Move this material quickly, but protect your lining while you do it.
That's a perfect way to describe its dual action there.
And how does it interact with somatic and visceral nerves?
5-HT is a powerful depolarizer of sensory nerve endings. When 5-HT is released locally, it activates those efferent nerve endings, causing classic sensations like tingling, pricking, or outright pain.
And when this activation occurs on visceral afferents, the nerves leading from internal organs.
That is what triggers the feeling of nausea and subsequently vomiting. Again, the rapid action of the 5-HT3 receptor is critical here.
And the platelets. Their entire role is to store it and release it at the site of injury.
Correct. 5-HT binds to 5-HT2A receptors on platelets, which induces a shape change and makes it a weak aggregator on its own. But its main function is as an amplifier.
An amplifier.
Yes. When platelets aggregate due to other stronger signals like thrombin, they release their stored 5-HT. This released 5-HT then amplifies the response, accelerating clot formation. Furthermore, the strong vasoconstriction it induces right at the site of injury promotes the essential retraction of the injured vessel, reinforcing the hemostatic plug.
Let's connect these local actions to the major disease states.
Yeah.
In the brain, its role as a neurotransmitter is indisputable, originating largely from the Raphe nuclei.
Its central role is immense. It governs everything from the sleep-wake cycle and temperature regulation to higher functions like cognition, mood, behavior, and appetite.
And the efficacy of SSRIs and TCAs in anxiety, depression, and OCD provides the strongest possible evidence that 5-HT dysregulation is central to the pathogenesis of these mood disorders.
It is the cornerstone of the monoamine theory of depression.
The brain also uses 5-HT as a raw material for another vital hormone.
It does. In the pineal gland, 5-HT acts as the direct precursor for melatonin, which is the primary hormone regulating the biological clock and maintaining our circadian rhythm. So 5-HT really does regulate the basic rhythm of life.
In terms of peripheral vascular pathologies, where does dysregulated 5-HT show up?
It's implicated in conditions of uncontrolled vasospasm. For instance, in Raynaud's phenomenon, where patients experience these acute, painful, vasospastic episodes in their fingers and toes.
Yes.
It's believed that the inappropriate release of 5-HT from activated platelets may be a key trigger. This is why 5-HT2 antagonists, like catanserin, were explored as prophylactic agents to block that constricting signal.
And what about the connection to high blood pressure?
Well, studies in hypertensive patients show two interesting things. First, their vascular smooth muscle exhibits an increased responsiveness to 5-HT. They're more sensitive to it.
Right.
And second, their platelets show reduced uptake of 5-HT. So this dual mechanism, more signal getting through, and the vessels being more sensitive to it, demonstrates how 5-HT dysregulation can contribute to the severity and maintenance of hypertension, even if it doesn't initiate it.
And finally, the condition that demonstrates 5-HT toxicity due to just massive overproduction. Carcinoid syndrome.
Carcinoid tumors, which usually originate from those enterochromaffin cells in the gut, produce and release massive uncontrolled quantities of 5-HT into the systemic circulation.
And the symptoms are a direct result of that excess 5-HT.
They are. The resulting symptoms are dominated by bowel hypermotility, which leads to severe refractory diarrhea, flushing, and bronchoconstriction.
And the fascinating metabolic complication here is pellagra. How did that happen?
It is a profound example of metabolic competition. Tryptophan is a precursor not only for 5-HT, but also for niacin, which is vitamin B3. When a carcinoid tumor is massively overproducing 5-HT, it hijacks virtually all the available tryptophan in the body, diverting it toward 5-HT synthesis. This leaves very little tryptophan available for niacin synthesis, and that leads to a clinical niacin deficiency.
And that deficiency is pellagra.
Pellagra, characterized by the 3 Ds, dermatitis, diarrhea, and dementia.
So we have a powerfully distributed multifunctional molecule. Early pharmacologists realized that if they blocked 5-HT, they could treat various symptoms, but they were really hindered by non-selectivity.
That was the initial barrier, absolutely. So many early drugs inadvertently antagonized 5-HT because of structural similarities between its receptors and receptors for other mediators. Alpha blockers, antisemetics, even general anesthetics showed some 5-HT antagonism. You got the effect you wanted, but you also got a whole host of unwanted side effects.
Let's look at some examples of these early non-selective agents, starting with cyproheptadine.
Cyproheptadine is a prime example of a drug that wears many hats. Its primary action is blocking 5-HT2A receptors, but it is also a potent H1 antihistaminic, and it has anticholinergic effects. So it was used historically for allergies and to manage the gut hypermotility in conditions like carcinoid syndrome.
The interesting anecdote surrounding cyproheptadine is its effect on appetite.
It dramatically increases appetite and promotes weight gain. This is a known side effect that was exploited clinically to help patients who struggle with poor eating or cachexia.
It also has a specific use in countering some side effects from SSRIs.
It does. It can be used to antagonize the sexual side effects like priapism or delayed orgasm that are sometimes caused by SSRIs due to its powerful 5-HT antagonism.
Then there is methizergide, a significant early player in migraine prophylaxis, but ultimately a therapeutic failure due to toxicity.
Methizergide is chemically related to the historic ergot alkaloids. It is a potent antagonist, primarily at the 5-HT2A2C receptors, and it was used for migraine prophylaxis because blocking those excitatory receptors helped to stabilize the vascular tone.
But the toxicity profile was disastrous for a long-term prophylactic medication.
It was. The sources mention fibrosis, a serious hardening of tissues.
What kind of fibrosis?
Chronic use of methazergide was linked to the development of retroperitoneal fibrosis in the abdomen, pulmonary fibrosis in the lungs, and endocardial fibrosis scarring of the tissues around the heart valves. This severe, life-threatening risk forced its removal from clinical use for migraine prophylaxis. It really marked the end of the non-selective 5-HT2 antagonist approach for chronic conditions.
This historical struggle just underscores the pharmaceutical challenge. Find a drug that only hits the target you want and absolutely nothing else.
Absolutely. And even when selectivity improved, like with ketanserin as a 5-HT2 blocker, there was always some cross-reactivity with alpha-adrenergic receptors. It's a testament to the fact that these monoamine systems are fundamentally similar at the molecular level.
We have to talk about the ergot alkaloids. They're the historical foundation of headache medicine, derived from the fungus Claviceps purpurea that grows on rye. The history of ergotism is terrifying.
It is a dark chapter in pharmacology for sure. Historical epidemics of poisoning were categorized by two terrifying forms. One was called St. Anthony's Fire, which involved painful, dry gangrene caused by extreme, persistent vasospastic ischemia.
And the other?
The other was a convulsive form involving hallucinations. These compounds are structurally related to 5-HT and noradrenaline, which explains their overwhelming systemic toxicity.
The classic drug here is ergotamine, which was used for decades to treat acute migraine.
Ergotamine is a nightmare of non-selectivity. It acts as a partial agonist or antagonist at virtually everything. Alpha-adrenergic receptors and all subtypes of 5-HT1 and 5-HT2 receptors, though thankfully not 5-HT3 or dopamine.
So it constricts vessels via 5-HT1 and alpha-adrenergic agonism. Why was it effective for migraine then?
Its efficacy came from its ability to cause powerful, sustained vasoconstriction. Crucially, the sources note that ergotamine binds to its receptors very tightly and dissociates extremely slowly.
A slow off rate.
A very slow off rate. And that means the constriction is prolonged, which effectively aborts the dilation phase of the migraine.
But the side effects were terrible, right?
Profoundly so. It's a potent emetic, meaning it often made the nausea and vomiting of the migraine much worse. And because of the powerful generalized vasoconstriction, chronic exposure or overdose could lead to severe capillary damage, thrombosis, and the very real risk of gangrene, mirroring that historical poisoning.
To mitigate this, pharmacologists developed dihydroergotamine, or DHE.
Yes, DHE is the hydrogenated derivative. This chemical modification makes it a significantly less potent vasoconstrictor and a weaker emetic compared to ergotamine. It's also a more effective alpha receptor blocker.
So it's less hazardous.
Much less. Because of its reduced systemic risk, DHE is often the preferred agent for parenteral, so injectable, administration in severe acute attacks in emergency settings.
Finally, we have ergometrine, also called ergonovine, which has a completely different clinical application.
Ergometrine is classified as the amina alkaloid. It has very weak alpha-blocking properties, but it retains significant partial agonism at 5-HT2 receptors.
And that specific action is the basis for what?
Its powerful uterotonic effect. It causes a traumatic contraction of the myometrium, the uterine smooth muscle. Because of this, its use is almost exclusively confined to obstetrics to prevent or treat postpartum hemorrhage.
So the same fungal source produces two drugs, ergotamine and ergometrine, that contract smooth muscle, but there's subtle differences in receptor affinity determine whether they're used for headaches or for preventing a mother from bleeding out.
That is fascinating pharmacological specificity hiding inside these very non-selective drugs.
Okay, the historical context shows the immense challenge of using non-selective 5-HT drugs. But now we arrive at the modern breakthrough, selectively targeting the 5-HT system to treat migraine. Before we get to the drugs, let's quickly define the current understanding of migraine pathogenesis.
A migraine is defined by a severe, pulsating headache, often unilateral, lasting for many hours. And it's accompanied by photophobia, which is light sensitivity, phonophobia, sound sensitivity, nausea, and vomiting.
And the immediate source of pain is the pulsatile dilation of specific, large cranial blood vessels.
That's right. The historical vascular and neurogenic theories have largely merged into a single neurovascular cascade idea.
What's the modern view?
The modern view centers on a trigger that leads to something called neurogenic inflammation. Sensory nerve endings in the dura mater surrounding the brain are activated. This leads to retrograde transmission and the release of powerful inflammatory mediators.
And the key mediators are?
The key mediators are 5-HT, substance P, and critically calcitonin gene-related peptide, or CGRP. This inflammatory soup causes perivascular edema, which stretches the pain fibers, and that's what creates the throbbing, intense pain.
The fact that 5-HT levels fluctuate during an attack and the efficacy of serotonergic drugs firmly establishes 5-HT's pivotal, though complex, role in this cascade.
Now, how do we treat it? We use a tiered approach based on severity. For mild migraine headaches that are tolerable, maybe less than one a month, the recommendation is simple analgesics.
Simple means paracetamol, aspirin, or NSAIDs like ibuprofen. Why the emphasis on taking them early and in dispersible forms?
Taking them early aborts the pain cycle before it becomes fully established, and the dispersible or liquid forms are vital because during a migraine attack, most patients experience profound gastric stasis.
The stomach just stops emptying.
It just stops. A regular tablet might just sit there, failing to dissolve or be absorbed, so the treatment is delayed and the pain gets worse.
For the vast majority of patients, those with moderate to severe migraine where they are functionally impaired, we have to move to specific anti-migraine drugs. And here, antiemetics are crucial, even just for the drug's efficacy.
Absolutely. Even if the patient isn't actively vomiting, they're often nauseated, and that gastric stasis is usually present. Therefore, antiemetics like metoclopramide or domperidone are frequently co-administered. Metoclopramide is particularly useful because it also acts as a prokinetic, overcoming the gastric stasis and helping the specific anti-migraine drugs get absorbed much faster.
This brings us to the molecular masters, the triptans. This class of drugs fundamentally changed migraine treatment by achieving the selectivity that ergotamine could only dream of.
The triptans are the new first line, and they are highly selective 5-HT1D1B agonists. They are molecularly designed to perform the exact actions we mapped out in Section 2. Constrict the dilated cranial vessels and shut down the neurogenic inflammation.
How precisely do they achieve this therapeutic effect?
We can summarize their action in 3 targeted ways. 1. Vessel constriction. They target the 5-HT1B receptors on the smooth muscle of the dilated cranial blood vessels, causing them to constrict. This reduces the pulsation that causes the pain.
Okay, that's the direct part.
2. Presynaptic inhibition. They act on 5-HT1D receptors on the pain-conducting nerve endings in the dura, inhibiting the release of those pro-inflammatory neuropeptides like CGRP.
So it stops the inflammation at the source.
And 3. Shunt closure. They selectively close the carotid arteriovenous shunts, which diverts blood away from the inflamed vessels.
Sumatriptan is the prototype. How did it compare favorably to the historical ergotamine?
Sumatriptan is highly selective, so its systemic effects are negligible compared to ergotamine. It's equally effective in aborting an attack when taken at onset, but it is far, far better tolerated.
And the crucial difference for the patient experience.
The crucial difference is that sumatriptan tends to suppress the nausea and vomiting associated with the migraine, whereas ergotamine drastically accentuated it.
But sumatriptan had a serious pharmacological limitation stemming from its short half-life and poor absorption.
It did. Its oral bioavailability is only about 15% due to high first-pass metabolism in the liver, and its plasma half-life is short, around 2 hours.
And this short duration leads to a significant problem.
Headache recurrence. In 20 to 40% of patients, the headache comes back within 24 hours as the drug concentration drops.
Which is why the delivery method is so critical for sumatriptan.
Absolutely. If a patient is actively vomiting, an oral tablet is useless. Therefore, it's available as a subcutaneous and SC injection, which acts within 10 to 20 minutes for severe acute relief, completely bypassing the gut.
And a nasal spray, too.
And a nasal spray, which also offers faster absorption than an oral tablet.
Given that triptans are vasoconstrictors, we must discuss the contraindications.
This is non-negotiable. Because they constrict blood vessels, triptans are strictly contraindicated in any patient with underlying cardiovascular risk. ischemic heart disease, angina, a previous heart attack, or uncontrolled hypertension. The risk of inducing a coronary vasospasm is just too high.
And you can't mix them with ergotamine.
Never. They must never be administered within 24 hours of taking an ergotamine derivative due to the dangerous cumulative risk of severe sustained vasoconstriction.
The sources mention the newer triptans, such as naratriptan and fovotriptan. Why bother developing them if sumatriptan was already so selective?
They were developed specifically to address the recurrence problem caused by sumatriptan's short half-life. Naratriptan and fovotriptan have significantly longer half-lives.
So they lead to fewer recurrences.
Exactly. They're better suited for patients whose migraines consistently recur quickly. However, the trade-off is they may take longer to provide initial pain relief compared to the fast onset of a sumatriptan injection, so clinical decision-making often involves balancing speed against duration.
Finally, let's discuss prophylaxis preventative treatment. When do we make the jump from treating the acute attack to daily preventative medication?
Prophylaxis is indicated for patients suffering moderate to severe migraine who experience 2 to 3 or more disabling attacks per month. The goal is to reduce both the frequency and the severity, and these are long-term regimens, typically sustained for 6 months or more.
The drugs used here are diverse and often repurposed from other central nervous system disorders. The leading class is beta blockers.
Yes, specifically propranolol. It's effective in reducing attack frequency in up to 70% of patients. And what's fascinating is that its prophylactic mechanism in migraine is still largely unclear. It appears to be entirely independent of its classical beta-blocking action.
If it's not blocking beta receptors, what's the current thinking on propranolol?
Well, theories suggest it may stabilize serotonergic or adrenergic neurons, perhaps by downregulating certain receptors centrally, or maybe simply by reducing anxiety and the sympathetic stress response that often precedes a migraine. We really only know that related beta blockers that have intrinsic sympathomimetic activity are not useful, which implies that some form of chronic receptor modulation is key.
We also use psychiatric medications like tricyclic antidepressants, TCAs.
Amitriptyline is the classical example. It reduces attack frequency independently of its antidepressant action, although it is particularly beneficial for patients who suffer from concurrent depression or chronic tension headaches alongside their migraines. It likely works by centrally modulating pain pathways.
And the newer classes include anticonvulsants.
Valproic acid showed early promise, but the major breakthrough came with topiramate. Topiramate is now approved for migraine prophylaxis and has demonstrated significant efficacy, reducing attack frequency by 50% in about half of the patients studied.
Topiramate's primary function is as an anticonvulsant, acting on GABA and glutamate pathways. Why does it work for headache prevention?
It dampens down overall neuronal excitability. It modulates voltage-gated sodium and calcium channels, it potentiates the inhibitory neurotransmitter GABA, and it inhibits the excitatory neurotransmitter glutamate.
So it just quiets the brain down.
In a way, yes. Since migraine is increasingly viewed as a disorder of a hyperexcitable cortex, the neurogenic part of the cascade topiramate works by reducing that fundamental electrical instability in the brain, making the patient less susceptible to the inflammatory cascade trigger.
Finally, we reach the most cutting-edge development, moving beyond the traditional serotonin and monoamine system completely, CGRP antagonists.
This is the future of acute and prophylactic migraine treatment. CGRP calcitonin gene-related peptide is the single most important neuropeptide released during the neurogenic inflammation of a migraine.
So it's the main driver of the pain.
It is. And erenumab, which is a monoclonal antibody, specifically targets and blocks the CGRP receptor. By neutralizing the most powerful inflammatory signal, this drug has shown profound efficacy in reducing the frequency of severe refractory migraines. It is the ultimate highly targeted therapy.
And it confirms the central role of neurogenic inflammation, which 5-HT helps initiate, but CGRP drives.
Exactly.
So we began this deep dive with 5-HT as a simple blood constrictor, and we've ended with a 14-receptor system that dictates mood, gut motility, nausea, clotting, and the specific mechanism of a splitting headache. The key therapeutic shift came when pharmacology moved from non-selective blasting with ergot alkaloids to highly refined molecular targeting, first with triptans, the selective agonists, and now with CGRP antagonists, blocking the inflammatory downstream signal.
If we connect this to the bigger picture, the journey of 5-HT demonstrates the profound power of understanding receptor subtypes. We moved from a dangerous broad-spectrum drug causing gangrene and vomiting to a drug that selectively constricts vessels in the head and turns off the pain signal chemically with minimal systemic impact. This evolution in headache therapy is a perfect case study for all of molecular medicine.
And that leads to our final provocative thought for you to reflect upon. We now understand that 5-HT agonists, the triptans, constrict vessels to treat the acute pain, and that the pain is driven by the release of CGRP. But the migraine cascade is complex. Given the success of targeting CGRP and the known involvement of 5-HT, substance P, and neurokinins in the neurogenic inflammation, what other currently unknown inflammatory mediators might be at play in initiating this entire complex cascade, and how soon until we have a receptor-targeted drug for them that moves us even further beyond the serotonergic system, offering a true cure rather than just suppression?